welcome to the Medical Technology and Innovation panel. As Raj said, I'm Maria, I'm a member of the ICGRx team, and I'm a fourth-year medical student at Dundee University. I'm very interested in medical tech, so really excited about this panel today. MedTech's a rapidly evolving sector. It's inextricably tied to innovation and this sort of new trend towards portfolio careers in medicine also. And if harnessed correctly, new medical technologies can really hold the key to making lives easier for both patients and our healthcare workforce. So we have an incredibly experienced panel here for you today who are here to share some of their insights. So before we begin, I'll maybe just get them all to briefly introduce themselves and their backgrounds, starting with Dr. Madhavan.
Sure, thank you, Maria. My name is Subha Madhavan. I'm the Chief Data Scientist at Georgetown University Medical Center. My team works with our clinical partners to really implement many of the medical technologies, leveraging data sets from clinical care processes to variables to other data collected from patients. My personal research interest is in precision medicine technologies. I'll talk a little bit about that during the panel today.
Okay, and Francis, if you would like to take over from there.
Yeah, thank you. My name's Francis. I've been lucky enough to work in the medical device technology sector for 30 years. And I've been in some small and large companies, from probably the largest Medtronic to the smallest startup. And it's fascinating to me to see how innovation is increasingly coming to the fore as the solution to a lot of the healthcare problems.
My areas of focus really is on deep learning for imaging, retina imaging for the last 5 years, and the portfolio has now gone on to chatbot, using the natural language processing. We are looking into blockchains applications in healthcare related, not just ophthalmology. And I'll be very delighted to share what what I've learned, and hopefully we can explore some potential collaborations with the rest of the audience as well.
Excellent. And Dr. Bansal, would you like to finish off the introductions?
Yeah, that's all very impressive from the rest of them. So this will be short and not as impressive. But I'm Sandeep. I'm a doctor by background, a GP trainee. And now I'm the founder and CEO of Medic Creations, changing communications as they happen across the NHS and healthcare systems, saving each nurse 21 minutes per shift and 48 minutes per shift for junior doctors by replacing outdated technologies like pagers, not just in the four walls of the hospitals, but across the community and GP surgeries, and reimagining how those communication pathways work. Right the way from social care through to secondary care. I also teach at Harvard Med around innovation and getting that into healthcare systems. As Francis said, that's really, really tough. So one of my key my key focuses is around change management, implementation, process redesigning, and actually embedding technologies so that they're used properly rather than just, here you go, here's a technology, go ahead and use it. So those are my kind of passions.
Excellent. Thank you so much, guys, for introducing yourself. A really impressive set of CVs there. I'll actually just sort of jump off something that Francis said for the first question that actually probably applies to you as well, Dr. Bansal. But you have this app, Medic Bleep, and it's aiming to sort of overhaul how we do communication in the NHS, which is frankly very, very outdated, the current communication methods in our hospitals. Why do you think healthcare organisations can be so slow to take on new innovations and new technologies?
Shall I go first before Francis? Yeah?
Go for it.
Cool. So I think, coming from a clinical perspective as well on this, I'm cognizant and, I have complete sympathy with the system and with the clinicians in the system. So change is tough, Firstly, you've got to think about how stretched we are in the NHS as a system, right? When I left clinical medicine in 2014, 2015, we were 95% net occupancy levels in the acute trusts at any given point in time, constantly on black alert. Now, what that means is literally, if you look at it, every hour, 15 minutes after a patient is discharged, somebody else is filling that bed. Now let's step back, does that really give staff members time to engage with change? It doesn't, it doesn't give them time to even go for a lunch break properly, if I'm honest, yeah? So when you don't have that time, how do you really get stuck in with change? Then secondly, pages, for example, have been around for 70 years. We've known them. This is how we've done healthcare. And it works. It's robust. You don't want to make changes when it's going to introduce risks. So it's all about clinical risk mitigation. And that takes time to prove out, how you're mitigating those risks. Then we're scientists. It's all about proof and evidence. And that can be a hurdle. Getting to that point of proof and evidence, because who's going to take the shot, who's going to take that initial pain as in the system to prove out a technology and an organization. And those are the hurdles that I see. Then, of course, NHS has some unique challenges around procurement. Yeah, so I can talk about procurement all day long, but that challenge really exists, So a typical sales cycle in the US would probably be about 6 to 9 months. In the UK, you're probably looking at 18 to 24 months if you're trying to make those same changes. So those are the challenges that I see off the bat, really.
Yeah, I can relate to the procurement thing. I've been involved with some projects trying to get blockchain more widely used in NHS for data sharing and things, and it can be a slow process. Frances, would you like to add to that?
Yeah, I think the risk profile is an important one. I think especially where healthcare is often set up, where the individual practitioner bears a lot of that risk profile on themselves, and their professional, qualifications would be called into court and all the rest of it, and then it would be, well, what does everybody else do? And okay, you've deviated from what everybody else does, therefore you're sort of liable. I think this is something that we all need to keep in place, that we want at least people not to want to take too many risks. But equally, I think technology companies have to work hard on the second phase. People bring a product or technology to market and think it's going to sell itself. Well, actually, in a company, I work for Olympus medical giant global company, and probably more money, or at least as much money, is spent on the commercialization of the tech as in building it in the first place. And I think this is often underestimated by entrepreneurs and venture capitalists and the like. And, we don't want to have it reckless that everybody adopts stuff willy-nilly. We need proof, we need evidence-based medicine. But sure, we need to say, okay, is this relevant? This is an app for so-and-so. Does it need to be so much studied as a pill that might save or kill you? So I think this is the graduation of how we assess some of these technologies could be improved. And I agree. Seen so many times people are in the coalface working so hard, they haven't got time to turn around to the salesperson who happens to have an explosion kit to help them remove that coal. And this is the way it's been for some time. And I think, yes, things are improving. And NHS England worked hard on different accelerators, and NHS Scotland have done things. And I'm sure it happens around the world. And we've just got to carry on trying to, fix the system as best we can.
Excellent. Thank you so much. And hopefully this will be something that improves going forward. People are engaging today. They're the healthcare professionals of the future. So fingers crossed, we'll make some progress with that. Does anyone else have anything to add?
Yeah, I just wanted to quickly add one additional point about challenges for incorporating technologies into clinical care. I think it's and I completely recognize what Frances and Sandeep were talking about, overburdened clinicians. And to that point, it's critical for these technologies to be incorporated into their routine workflow. So if you have this tech sort of sitting on the side and you want them to go outside their typical workflow to access that technology, it's never going to happen, right? So I think this goes to the point of not throwing it over the wall and really trying to incorporate into the workflow. And I think as digital health technologists, we're beginning to understand that, and every organization, every hospital system is different, and they have unique workflows and guidelines that they have to follow. So how do you sort of customize the digital technology for a better uptake? I think is something that, I'm hopeful as digital technologists, we can solve that problem by incorporating it into their current workflows.
Great. And Dr. Teng, anything to add?
Yeah, I'll just add on from the innovation part of things. Sandeep, Francis, and Shubha has really touched upon very important points in terms of how we should clinically integrate all these technologies, within the workflow and stuff. But I also wanted to not discourage the innovators from thinking out loud and dream big, and to see really what are some of the clinical unmet need that could actually potentially be addressed by some of the newer technologies, because some of the things that doesn't work for the current clinical workflow doesn't mean that it can't work in 10 years time. So I do actually want to come from the other angle, and I can't agree more that the implementation, adoptions, getting the buy-in from the clinicians, regulators, and the patients actually takes much more time compared to how you actually how you originally build a product. I can just give you an example. I was actually involved in the front line just 2 months ago in Singapore. So basically there was a operational unmet need in terms of how we're going to communicate with a doctors to patients ratio of 1 to 400. So literally we are trying to manage about 2,000 to 3,000 migrant workers in Singapore that have COVID-19 positive. And then we only have 15 to 16 doctors during the day shift to manage the 4,000 patients. How do you manage such a high throughput of the patients during the crisis period? So those are the things I also wanted to put in the context of the COVID-19 a little, to see literally we built a basic app within a 2 weeks period. But in terms of adoption, clinical implementation, discussions, and to really support the whole chatbot project, it actually takes us about a team of 20 to 30 people. So the app itself came up within 2 weeks, but the ongoing maintenance of the app and the support, the back-end support, really requires a multidisciplinary, approach to actually do that. So I think these are just a very, recent example that I had, apart from outside the ophthalmology settings that I can actually share more later as well. Yeah.
Excellent. Thank you very much. Really interesting insights there. I think you're right. I mean, we have to be multidisciplinary. That's what we're all about in medicine, and that also applies to med tech. To pivot slightly to talk a bit more about data, some have said that data is the new oil. Data can be highly monetized, including healthcare data. Going to Dr. Madhavan first, what do you think the main barriers are to data collaboration globally between institutions? For example, during coronavirus, we need to share data as a planet to move forward. And what do you think the main barriers are to that?
Yeah, I always wonder about that metaphor. Is data really the new oil, right? Because it's data is actually in some ways much better than oil because it's renewable. It can be reused over and over again, right? So I think it's a really good question about how do we collaborate around data. I think the number one point to make there is really one of trust and verification, right? And if you even just look at the global pandemic and, there are numerous COVID registries that are being constructed. Every organization is constructing one. And to give you a US perspective, every state is constructing their COVID registries. And, then you've got social media and other large systems. So the question is, how do we utilize the existing data resources appropriately and not being redundant and creating these resources over and over again? And that really requires a lot of trust and making sure that, either working with clinical partners or public health agencies, we have the right governance processes and right security and privacy policies in place to make sure that data can be shared to advance discovery, but at the same time, the data owners are confident and comfortable about sharing it outside of their firewall. So trust, you always have to add verification with trust. So even if I have this great working relationship with a bunch of public health organizations over the last 20 years. Unless we can show that we can verify and make sure that we are confident that this data is accurate, right? So I always joke that there are a lot of well-intentioned bad actors, right? So people actually want to do the right thing, but if you don't have the right policies and technologies, you might end up doing the wrong thing. So I think trust and verifications are key. Another point I would like to add is about governance, right? So data governance is critical within organizations. And I think to Daniel's point, we don't want to stifle innovation. So there needs to be, some sort of a meet in the middle where there are existing policies that support the clinician to take care of patients today, but then also allowing technologists to innovate for the future. So I think that's sort of how do we sort of meet in the middle with these two agendas coming together. So I think these are important considerations for data sharing and data access.
Definitely, and I think any new innovation or technology that's gathering and storing data needs to be trusted and verified. You're correct. Does anyone want to chip in on this and maybe talk a bit more about how we can ensure these things are safe and trusted?
I'm happy to add a few thoughts. I think there's a couple of aspects to it. One is that there's a little bit of cynicism in certain sectors of the population. I would include myself in that, and a lot of the so-called companies that build their business on data it's gone out of hand in some contexts, and arguably taking down democracy and all sorts is being alleged. And I think the fear is that medical data could be misused in the future, even if it's not now. And I think that trust barrier needs to be overcome. I think the other piece to it is that medical data is no different than any other data in the sense that you need so much of it to create artificial intelligence and machine learning that's any good. And unless we can sort this out and learn how to have data sharing agreements, I think it will be very difficult to realize some of the promises of technology in the future. And I really hope that we can figure it out and not just build walled gardens. We have a bit of a walled garden in Olympus with our digital data from endoscopies, which is fine for now, but I hope that in the future there'll be ways of making that sharing more possible, but still maintaining safety and trust.
Excellent. And does anyone else want to come in on that as well?
Yeah, I'll chip in if that's okay, Maria. So I completely agree with Suba and Francis. Governance is so critical. Until you get the foundations of healthcare data right now, there's no point thinking about building amazing AI, other technologies on top of that, because it's all about how is that data being shared appropriately with the right consents from patients and the data owners at the end of the day. Secondly, then it's all got to be tagged appropriately and validated and verified that it belongs to the data set that we're saying and talking about. Only then can you really get truly and leverage truly, AI. Without the right tagging, there's no point to any of this. All the massive data that we've got in the NHS, great, but they're not tagged appropriately. So we can't actually build those technologies going forward without all of that in place. But getting the basic steps and the governance right now, it's even more critical now. So COVID, we've seen the track and trace, So how does the public trust track and trace? And we've got to get the fundamentals of that right here now. Otherwise, we might damage, how the public and the citizens view us healthcare providers with trust, and if they don't trust us, they won't allow us with their data sets. So that's really key.
And Dr. Teng, I know you have a background in AI and blockchain and things, so do you have anything to add from that perspective?
Yeah, I mean, this topic I can talk for days. Yeah, so I just wanted to echo all the points that Shubha, Francis, and Sandeep has made, and in fact, I am getting a bit more concerned about how the field is trending towards, because the governance, I'm not sure. I mean, though it's very important and it's really essential to make sure that the patient's privacy and stuff is being ensured and stuff. But I mean, sometimes I wonder whether we are overdoing it. That's number one. The whole world, you look at states, they have like so many different states regulations, the HIPAA rules, it differs from states to states. Even within states itself, you have problem sharing data. So, I'm just very worried that, one day the whole world is just is getting so territorial in terms of, the data transfer. The second thing is that, how much, comfortable we are to handle like the de-identify and anonymize data. Of course, like de-identify versus, anonymize are slightly different. I handle like the retina imaging all the time. So people always say, oh, retina photos probably is one of the highest, the identified, like the unique, the features of your in terms of the form of identity, like people use fingerprints, iris, scanners and stuff. But if you really want to talk about the highest level of the security, you talk about retina imaging, because that is the one most, unless you start having some age-related macular degenerations and stuff, and you start changing the retina features. But having said that, like if you just look at the retina image alone, you don't actually know whether this guy's a male or female, or the age of the patients and stuff. But if you actually train it properly with AI, you can actually do that. I'm not sure whether you guys are aware of the Google paper in using the retina imaging to predict someone's gender, and the age and cardiovascular risk factors. In fact, I was one of the reviewers of the paper and wrote a commentary on that. When I first saw the paper, it was shocking. So I was like, that can't be true. Like, how do you, possibly determine someone's like age or, the gender based on just retina imaging alone? So, I mean, this is also some potential the issues with some of the data that you think is anonymized and de-identified, but if you actually use some powerful deep learning algorithms to do it, it may not be so private anymore. So these are some of the balance that we constantly think about, like how much to do, how much to push, and of course, we want to be like an Elon Musk and getting people after the Mars and stuff. But at the same time, we are actually managing patients in the healthcare setting. So we also kind of have to achieve a little balance in that. The third point I wanted to raise is that everyone talk about safe, secure, trusted. So then blockchain, of course, like what Marja you're doing, right? Like you're looking at how you use blockchain and all these things into ensuring that. But whether or not we are overhyping about the blockchain applications and in fact, sometimes do you even need blockchain to do it? That's also something that the questions you have to answer, all the time. And is it cost effective to use blockchain to do this? And whether you use a public or a private chain to do it, and what kind of the nodes and the environment we are talking about, so there's like tons of different issues that we can actually go on and on and on. But I just wanted to encourage again, like I being like someone who loves to innovate, I always like tell my the fellows and stuff, I say like guys, just think of if there's no rules, you want to do anything, like just try to do something, and then we will work around the ecosystem that could actually support the AI or blockchain technology around it. So I think that's something I want to make. Yeah.
Can I just quickly add? This is very provocative, and I have to respond to this. This is fantastic, Daniel. I think I would say that the sooner we embrace, we as technologists and innovators, the sooner we embrace that the trust and verification processes that need to be put in place, or the ones that are already in place that need to be embraced, you can get your innovations more quickly into the system. So I think about this a lot, right? So there are 3 paths that I always, for every project, I think of 3 paths. Is it PHI data? Is it personally health identifiable information? Second path, is it LDS? Is it a limited data set where you need dates and event times? Or is it completely de-identified and anonymized data? And I think this goes back to your point about the Google paper, right? And so I'll give a different but a similar example for that thread. you only need 75 genetic polymorphisms to uniquely identify an individual. Just 75 polymorphisms out of 3 billion bases in the human genome, right? So if I had a database, a reference genome with a bunch of individuals and their genomes, I only need 75 spots, those data points. So when we say that data sets are completely de-identified from a HIPAA perspective, meaning they don't have the 18 identifiers, right? So the date of birth and your address and your social security number, etc., that data might still need some additional trust and verification. So I think it's helpful to think about the innovation in this framework, right? So what exactly is the data? What are the roles and responsibilities? Who's going to touch this data? At the end of the day, I'll say that nothing succeeds like success, right? So if you are able to demonstrate that success, even to a small group of people, and I think, Daniel, you're trying to make that point, which is show that small use case, make it use case driven, show that success in a controlled environment, and then there could be wider adoption. I always worry about innovators and technologists having these great solutions which really don't see the light of the day. So I think, again, the trust and verification framework, and then the innovation, how do we balance that? And in some ways, I think as technologists, some of that onus is on us to make sure that our technologies do see the light of the day.
Yeah, thanks, Shubha. I think I can't agree more. And in fact, some of the things I'm trying to do in my digital lab is to encourage people to design or to really build something within the simulated, the digital workflow. So it doesn't mean that today, because my current digital workflow doesn't allow me to do so, I'm not going to do anything about it anymore, right? I'm not going to innovate around it anymore. Instead, I'll just ask him take a step back and look into the clinical workflow rather than the digital workflow, and then build like your digital workflow based on what the clinical workflow is. So it's no longer bench to bedside. I always say start with the bedside and then identify the unmet need, go back to the digital environment, create like a solution, and then see whether you can do it in a simulated manner in the research setting. Once it's done, it's being clinically validated, go for all the regulatory approval that you need, and then do clinical trials in a clinical setting in the prospective manner. So I think that this is like the way that usually how the studies goes, like research to bench. From bench to bedside. Yeah.
Excellent. Thank you so much, guys. You're actually answering a lot of the questions I had as you go along, which just goes to show how deep and wide-ranging this discussion is. A question probably for all of you. I'll maybe direct it to Francis first because he's the only non-medic, as we like to say, on the panel at the moment. What first attracted you to the field of medical technology, and how can healthcare professionals and their tech counterparts collaborate efficiently and work together?
Yeah, it's well, I was first attracted into the medical device industry through a friend of mine who had his own small company, and he was innovating in respiratory care and anesthesia. And it was fun just to work in the little office there and try and assemble things to solve problems, and really see them sometimes become kits or products that helped patients. And I think what that brought to me was a twofold thing, really. One was the love of innovation, and the other was love of helping the patients. And mum from nursing and all the rest of it, it sort of didn't hurt to sort of have that in the back of mind. And I think in terms of working together, I mean, if you look at any medical innovation, pretty much, I would say it's been a combined effort of clinicians and industry working together. And I think this is something that we need to increase and cement that relationship. I mean, there's been all sorts of bumps in the road with, allegations of it being improprietary and all the rest of it. But essentially, this is how things get done, right? That we work together to solve a problem for a patient. And I think if you look at a company like Olympus, as I said, work for them, innovation from clinicians in the UK, become products out from Japan and solve problems on a global level. And I think this is how it needs to work. And what worries me a little bit at the moment with the lack of being able to really get face-to-face engagement is how we keep that relationship alive and how we keep that synergy and how we keep that buzz of creativity flowing, back and forth between the clinical team and the industry partners. And I really hope we can solve that and, keep it alive, at least in the interim, with, things like this, video conferences and so on.
Definitely. And I saw you unmuting there, Dr. Bansal. I wondered if you had something to add to that.
No, I completely agree with Francis that it's completely multidisciplinary, and without the clinicians' involvement, without technologies' involvement together, you can't get great solutions to the problem. And other stakeholders, actually, it's not just even about clinicians; it's operational staff members. How do you make something operationally work in the organization? And then you've got other stakeholders, the purchaser and buyer, and the health economic side of things, and that sort of impact. So actually, it's much wider than just the clinician or just the technologist. Yeah.
Would anyone else like to come in on that? Yeah. What about yourself, Doctor? Oh, you agree? Good. Agree. It's good to agree. Dr. Ting, do you have anything to add?
No, nothing to add.
Okay, good. Well, we have about 10 minutes left, so maybe we can just sort of bring things to a close by getting you all to give some advice for people who are interested in getting into the field. All of you come from sort of different fields, really, but they all come together under this umbrella of medtech. So some advice for either healthcare professionals or even non-healthcare professionals for getting into the field if they're interested, and also maybe just briefly what you think the most impactful medical technology discovery or innovation has been in recent years. Dr. Ting, we'll start with you.
Yeah, I think this period is probably like one of the best period to innovate. Like, we call it as a crisis innovation right now, like what Winston Churchill says, right? Like, you should never let go, you should never let a good crisis to go to waste. I mean, that's something that is really, really true. And in fact, pre-COVID period, we know there's a lot of even like the Harvard Business Review, we know, like, they actually publish, they actually publish something on how patients are not trusting the application of the AI, and, the physicians themselves, they also written lots of different editorials to kind of like, caution the field to really adopt the AI without, rigorously testing them. That's like totally right. But sometimes if you actually, again, coming from, you see like two different schools of, the physicians. One is like the one that they're prepared to embrace the technology and of course, with a very rigorous and, careful evaluation and testing and stuff. One is no matter what you tell him or her, they will just never move because they say like, why AI, and is our job going to be affected if we actually allow some, alternative solutions to come into, take up some of our jobs. So those are the uncertainties and anxieties. But because of COVID, like, it leaves us with no choice. Like literally the whole global is suffering, experiencing lockdowns, quarantines. Your patients' waiting times is shooting up to the sky, and there's the backlogs of patients that need to be treated. You have actually left us with no choice to really embark on the digital technologies like telehealth, telemedicine, using video consultations to talk to your patients, even though we know that's like the 100% perfect solutions for them. But that is actually, in fact, after you throw out like a few good use cases and stuff, you start realizing actually that's not too bad of an idea to actually start talking to your patients through the tele platforms. So those are the one thing that I would like to encourage the readers to, or like, the audience to really like a ride on, because this opportunity doesn't come very, it doesn't very, it's not, this is something like once that happens once in every, I don't know, like 50 years or 100 years, when's the last time that something like this happened? After the SARS, right? This is like the next one after SARS, in COVID. And secondly is when I present in a lot of conferences, people say like, I'm interested in this, how do I start? And I don't have a computer science background, how can I even start getting involved? I say like, just start reading, start talking to people, attending the conferences. And then, I think you always have to start somewhere. And start small. Start with someone that you know around you. I think that's always take baby steps. I don't say like I want to like just come up with publish in NEJM or like JAMA the next day. No, it's not going to happen like that. So yeah, I think read around, make more friends, and embark on the and grab hold of the opportunities. I think that there's something that I would actually encourage the audience to do. Yeah.
Definitely. So, Dr. Madhavan, if you want to add your 2 cents on that, advice for people looking to get into the field, and also a favourite medtech innovation if you have one, as brief as possible, because we've got 5 minutes left.
Sure, absolutely. I'll be quick. I think to add to what Daniel said, there are numerous opportunities to educate yourself, right? So there are massive open online courses. They're called MOOCs, you name it, Coursera, edX. There's so many platforms where you can go and learn the fundamentals and the basics of machine learning, natural language processing. How is it being applied to different clinical workflows? Just a quick plug, if you really want to learn this, there are a number of universities, but we also have a health informatics and data science program. So you can go to healthinformatics.georgetown.edu. It's a 1-year master's program that really trains you on digital health. We have a whole course on AI applications in healthcare. And I would say definitely, reading papers and developing your network, right? So that multidisciplinary collaborative network is critical, because if I only talk to AI developers, then my viewpoint is going to be very narrow. So make sure that you're keeping that broad and open. In terms of what's my favorite, if I can say 2 things very quickly. One of my favorites is really risk prediction in mental health, because it's a huge challenge globally. With suicide ideation prediction, all kinds of mental health issues, more so now with COVID. Could we use voice of people to really do that risk prediction? Who is it that really needs immediate help? And who is it that just needs to go talk to a friend or do some meditation or yoga? It's very, very hard to do that risk stratification today for mental health. And we end up losing a lot of people to suicide and other disasters. So how do we sort of intervene with digital health? And I think that's a very ripe area for digital health to intervene. One final example I'll give is virtual tumor boards. And this is very close to my heart. So in precision medicine, you may not have all the expertise locally in your medical center or your research center. Using a telehealth type platform, which is asynchronous, you can use a virtual tumor board to bring the best knowledge for that particular cancer patient. Right, so now we're doing molecular analysis of cancer patients on a routine basis, but each center may not have the full expertise to interpret the clinical data and the genomic data. So having a virtual platform that brings experts into this, those are my 2 favorite digital health platforms today, and I am very bullish about both of them.
Excellent, brilliant, thank you so much. Dr. Bansal, would you like to go next?
Yeah, sure. So for me, going on Subha and Daniel, it's about the network, and it's about you reaching out and being proactive with it. So I would say get a mentor, who's 10, 15 years experienced in healthcare informatics and technology, understands where it's all going, and make them a mentor of yours, and check in on them, with them once a month, get a coffee, and they can help you open up their networks, and put you in touch with the right conferences or the right reading material, or I think having a mentor, that's probably been the best thing that I've done in my life. Then the second question is around what innovations do I think are pertinent? So at the moment, let's go off a COVID-related one. So I think point-of-care testing is going to enable us all to get back outside. So for me, that's going to be a really, really vital one. And I think, coming back to medical education, I think, you guys, medical students, haven't really had the chance of doing OSCEs, for example, and bedside teaching. So I think anything that can help with that sort of virtual reality, I know Geeky Medics do great videos, for example. Simple stuff, just done really, really well. Virtual reality platforms doing OSCE training for bedside teaching, keeping that continuum and making sure that clinicians still progress and, we're still making great doctors. So I think that to continue the healthcare system for me is really critical.
Excellent. Thank you so much. And I really agree with your point on mentorship there. I think it's something that a lot of people often forget. So thank you for bringing that up. Francis, if you'd just like to close things off for us with your views, no pressure. Last part of the panel.
Yeah, thanks. In terms of favourite innovations, I think I've been superbly impressed with the flexible endoscope technology that Olympus invented 70 years ago. But my favourite from my sales environment is this little thing here. It's the AliveCore ECG. It's the first smartphone-based ECG, inspired Apple to build it into the watch. And I think Dr. Dave Albert, the inventor behind that's a really great guy. And in terms of advice, take the long view. Don't rush. It's not going to be solved overnight. I think that's one. And second of all, to agree with Sanjeet and the others, is everybody else involved are all on the same mission, really, which is to help patients, and they will help you. It takes a village to raise a child, but it takes a lot more to get medical technology out there, and we're all in this together. And I think it's a wonderful industry, a wonderful partnership with clinical teams across the world. And I think I got into this perhaps by accident, but I tell you what, I would never leave it. It's the most wonderful thing to feel that you're actually contributing somewhat to human health.
Definitely. It sounds like a happy accident. Thank you so much, guys. That's the end of our panel.